I definitely promote your book, Mike. I read
Thanks.
it and I recommend it here and there to patients to pick up.
No, I appreciate that. What
You
sort
did
of
it. You
feedback?
did. You did a great job, man. No, people like it. I mean, I think the references are just incredibly solid, and you just bring to light a lot of new research that nobody, even including myself, is just not even doesn't have the time to kind of put it all together. So it's awesome to see all that new stuff put into a book and kind of start thinking about things. It definitely got me thinking about things a little bit differently in regards to my obese patients and stuff.
Great. I appreciate that feedback, and anything that I can do differently or improvements, just let me know.
That's great. I just have a hard time chewing 40 times. I've been practicing.
Yeah, we get a laugh in my household about that recommendation also, but we strive for it. Doesn't seem to happen.
I think maybe 2 swallows per minute. I think it's about that. I don't know. You don't want to be counting every chew and so forth. So I think just being a little bit more practical with that, and as long as you eat with with people, like is what most people should be doing anyway, eating with a group or someone and talking, you're not going to be just scarfing down food. I think the problem is when you're mindlessly eating and driving and watching TV or whatever, you're not really cognizant of that and just taking these big bites and not really chewing and swallowing whole clumps of food, and I think that's where the challenge comes in.
Yeah, and if you get used to putting a knife and fork down in between every bite, it helps a lot too.
Right. And just eating at the table. I mean, I'm guilty of it too. If my wife's cooking, I sit there and sample and chew stuff, and you're not even really aware of what you're doing. So
yeah.
Simple strategies.
As a regular customer saw an integrative medicine doc in Boston that suggested compounded rectal DHEA suppositories to minimize the first pass effect by the liver. So since DHEA can be metabolized to more than one hormone, is there a way to compare the oral dosing route that does get impacted by the first pass effect versus the rectal route?
You could try to do this in a variety of ways. It would be kind of cumbersome at best. I mean, my opinion is oral DHEA does a very nice job of giving a predictable rise in serum DHEA-S levels. If a man is taking 25 to 50 milligrams of DHEA, usually see a nice predictable rise. So presumably, even though it's going through hepatic metabolism, you're getting to the target increase that you're looking for in terms of the DHEA. You could bypass the liver, definitely going with the rectal route. I'm just not sure what the clinical utility of that is, if that is also going to rise serum DHEA-S. You could differentiate between the two by doing an experiment. You could take oral DHEA and do a 24-hour, urine collection, and then versus the rectal DHEA, and then you could look through the steroidogenic pathway and see if, anything was changed with rectal versus oral in terms of hepatic metabolism differences. But I'm not sure what the utility of that would be, or if that, would be very useful clinically.
Well, it goes on to say that the individual is trying to get the benefit of DHEA the most cost-effective way possible. Is there much of a difference between the oral and the rectal cost, do you know?
Well, I would think anything compounded is going to be more expensive, than an oral over-the-counter supplement.
Would you use the same kind of dosing rectally?
Presumably, rectal absorption would be a little better maybe than oral, but it would probably be roughly 1-to-1. Maybe you could get by with a little bit less rectally.
Okay, thank you. I'll share that with.
Yeah, I think that stems from Bettina. Jonathan Wright talks a lot about that. And so the mucosal delivery of different hormones seems to be a little bit better, and there's less hepatic and, like Jeff was saying, different conversion profiles and so forth. So I think that's where that original question was coming from, maybe a student of Jonathan Wright's. And so he recommends vaginal delivery of estrogens and so forth for women, and also rectal delivery of androgens for men. I guess there's less receptor downregulation, less conversion, and so on. But then, of course, I've read online that testosterone administered in that route can have increased aromatization and 5-alpha reductase activity because there is higher levels of those enzymes near the skin. So really, like Jeff says, is just test it and see what happens after dosing.
Yeah.
So, and plus the compliance, I mean, I think that would be a little cumbersome. It's easier to swallow something as opposed to dosing things rectally, right?
Yeah, there's practical dimensions to that. And, if you look at most of the studies, they're mostly using oral DHEA. And it's an interesting idea, but again, you can use what's tried and true. It seems to work pretty well.
There's a topical version also of the DHEA,
which Simonton offers. So, All right, well, we'll go ahead and get this thing rocking and rolling, everyone. Thanks so much for being with us. I know there was a small glitch with the server this morning and trying to get registrations in. So thanks for dropping me a note on that. And I did send out an email to some of you that did experience that issue, but have quite a few on the line. And we're very excited to have functional medicine and anti-aging expert with us, Jeff Grimm. Jeff is a graduate from Columbia University and did his postgraduate work there as well, receiving his master's degree in nursing. He's a nurse practitioner and is very involved in functional and integrative anti-aging medicine and the overall medicine community in the Portland area. And he currently works at Restore PDX, where he does a lot of bioidentical hormones and anti-aging work. So, Jeff, welcome.
Thanks, Mike. Thanks for everybody. Happy to be here. Excited about presenting, my take on bioidentical hormone replacement in women. I'll go through my slides shortly, but basically we're going to review some of the studies. I have some exciting slides showing why we're excited about BHRT, and in regards specifically to, everybody's concern with cancer, blood clot risks, and those types of things, and what the literature has to say, comparing bioidentical hormone replacement with conventional hormone replacement for women. So I guess I'm going to go ahead and get started here. Mike, is that right?
Sounds great. Take it away. Thanks.
Okay. So here we go. So what we're going to hope to accomplish today is some definitions, HRT versus bioidentical hormone replacement. We're going to review the Women's Health Initiative study and kind of bring to light some of the major issues with that study. That study has been reanalyzed a few times, so we have some new ways of looking at the results of that study. We'll talk about signs and symptoms of various female hormone deficiencies. We'll talk about diagnosis and monitoring, common dosing forms. I'll try to explain some of the compounded terminology and kind of making sense of that. Fielding common complaints, side effects of therapy, common complaints of bioidentical hormones, and then at the end we'll talk about some nutraceuticals that are relevant for our patients that are on hormonal therapies. So traditional HRT refers to the use of synthetic or semi-synthetic hormones. Some examples of this are the progestins. MPA is medroxyprogesterone acetate, or Premarin, which is horse-derived estrogen. Bioidentical hormone replacement, as many of you know, involves the use of steroid hormones that basically look identical to what the body produces. So saying they're natural is kind of a misnomer. They're basically natural derived, usually from plants like soy and yam. And then they're tweaked in a laboratory to make them look identical to the hormones that a woman produces. So I usually explain it that way, that they're sort of quasi-natural, but at the end of the day, they're identical to what the body produces. So talking about the Women's Health Initiative study here, the WHI study, came out in 2002. It basically showed that women who were using synthetic versions of hormones had an increased risk of breast cancer and heart disease. Mean follow-up of 5.2 years. The study was stopped early due to the increase of breast cancer. This created a huge kind of hoopla in the medical community. Many women were pulled off of hormones, and there was a recent study even showing that there could have been something like 60 or 70,000 preventable cases of osteoporosis due to just pulling women off of hormones. On the plus side of the arm of the study, they had decreased hip fractures and decreased colorectal cancer. So what's going on with this study? Why did the study show such an increase in cancer? There's a few problems with the study, which I highlight here. The major problem is the average age of the women in the study was around 60. These were nurses. They were obese. 49% of them were smokers. And a lot of people don't realize that. So the mean age you can see at the bottom of the slide here is 63. Here's another interesting fact that I learned recently. Women with hot flashes were actually excluded from participating in this study. So we basically took, older women who were smokers, who were obese, who didn't even have symptoms of low hormones, and put them on a bunch of synthetic hormones and saw what happened. So that's what I kind of highlight here. In 2011, the Journal of Clinical Endocrinology concluded that the risk discovered in the WHI study cannot be applied to women starting HRT shortly after menopause. So that's another interesting point. Even if you're starting synthetic hormones after menopause, the endocrinology folks are even saying, well, you can't even really apply the results of the WHI study to women in that category because, again, the average age of hormone, starting in that study was age 63. We now know that when estrogen is given less than 10 years after menopause, it protects women from heart disease and all-cause mortality. This is another justification for getting women started on hormones early after menopause. If you start a 75-year-old woman on synthetic or bioidentical hormones, you're probably not protecting them very much from Alzheimer's disease or heart disease, according to a lot of recent studies. The study used synthetic hormones only. That was another flaw, which we think is a major flaw because when you look at studies done on bioidentical hormones, which I'll do in a minute, they were not associated with the same risks. As bioidentical hormones were not studied, the question arises, can we apply the data from the WHI study to our cohorts of women using bioidentical versions? And I would say you cannot. And in lieu of recent research, you have to use studies that were done on bioidentical hormones when you have conversations with your female patients regarding risks associated with HRT, specifically in regards to heart disease and breast cancer. Interesting fact about progestin, a lot of people think progestin is the main culprit when it comes to the increased risk of breast cancer in these patients in the Women's Health Initiative study. So progesterone and synthetic progestins have similar effects on endometrial tissue, but there's significant evidence that they have differing effects on breast tissue proliferation. So that's an important point. We know that women who produce more progesterone before menopause are at lower risk of breast cancer. So real progesterone seems to have a protective effect on the breast, where synthetic progestins seem to have the opposite type of effect. And here's some scientific references for you on that point. Synthetic progestins have a clear association with increased risk of breast cancer, and you can see some of the references there in the slide. Here's some more review articles. Here's one from Turitasa in 2008. Could transdermal estradiol and progesterone be a safer postmenopausal HRT? So that's a good reference for you guys looking at, some of the other folks out there and what they're saying. One of the review articles I really like is this next reference here. It's done by Eileen Conway, who's an osteopath, and she wrote a great review article of all the literature on bioidentical hormones, and she concludes that bioidentical hormones that are approved by the FDA may be preferred over standard hormone replacement because of their physiologic benefits and safety profile. This next study is the most important to date. This is the one that I share with all my female patients when people come in and they say, don't hormones cause cancer? Or when I'm talking to other providers, and I often have conversation with other docs and they're saying, what are you doing giving women, hormones, at age 70, 80, why are you adding progesterone with your estrogen? Why are you using testosterone? And all those kinds of questions. This Fournier study was done in Europe, and it's our most important study to date, looking at the risk of using combinations of bioidentical estrogen with progesterone. This study was done with about 80,000 women, and they showed no increase or decrease in breast cancer in women on estradiol and progesterone. So if you've got your women on combinations of estradiol and progesterone, this is the biggest study to date to show people and tell people, hey, this stuff doesn't look like it increases your risk of cancer. You have the same risk, relative risk of 1.0, as somebody not on any hormones at all. However, in another arm of this study, estradiol mixed with medroxyprogesterone acetate, you had a relative risk increase, 1.69% of breast cancer. So again, the conclusion here, over and over again, is that progestins are not progesterone. Progestins are not progesterone. And the biggest confusing point here is if you do a PubMed search, you type in, progesterone breast cancer, you'll see abstract titles that say, progesterone associated with breast cancer. So for the average OBGYN clinician or layperson looking at the abstract title, they draw the conclusion progesterone causes breast cancer. But when you dig into the study, they are not talking about micronized bioidentical progesterone. They're talking about progestin. And it's just a shame that there's such semantic problems, which just adds another layer of confusion when it comes to this whole topic of hormone replacement. So here's what real progesterone looks like. Some facts about progesterone. Decline begins about 10 years before the onset of menopause. Many women with symptoms of low progesterone get put on antidepressant therapy in this time, which is very interesting. You know, often in clinic, you'll have women presenting, you know, age 40. They're having worsening insomnia, anxiety, or depression. They see their PCP. They get put on Prozac. And my kind of joke in the office is they get put on Prozac when they needed progesterone. Here's some functions of progesterone. You can kind of read through the slide, but basically, this is a hormone that helps build bone. It's a natural antidepressant. It has a calming effect through an allopregnanolone GABA activation pathway in the brain. We know it's neuroprotective. It enhances immune system function. It's anti-inflammatory. And, of course, it balances estrogen. When women come in with symptoms of low progesterone, if they're premenopausal or peri or postmenopause, here's a list of some of the symptoms. You know, in premenopause, typically these are things like irritability, insomnia, PMS, fibroids, endometriosis, fluid retention, bloating, fibroids, fibrocystic breasts, breast tenderness, all those types of things. Achy joints can also be present, and menorrhagia and dysmenorrhea. So for those women, we usually offer progesterone, and this is done classically by giving progesterone to mimic how premenopausal women produce progesterone naturally in the ovaries cyclically. So we usually dose oral progesterone as micronized progesterone somewhere between 50 and 200 milligrams. Typically this is dosed at bedtime because progesterone can have a slightly sedating effect. And we usually do that days 12 through 26. If the woman has a longer cycle, you could do day 14 to 30, or you could adjust it accordingly. If they have severe symptoms, like they have a lot of mood alteration or anxiety or irritability in the first half of their cycle, you can use smaller doses of progesterone to give them coverage. Some clinicians do that day 1 to 13, and some clinicians do that after menstruation to about day 12 or 13. So that could be like day 5 to 13, for example. Topical progesterone can also be used. Clinicians tend to use doses somewhere in this range, 10 to 20 milligrams up to 100 milligrams, depending on absorption. If a woman has a severe progesterone to estrogen imbalance, like maybe in the case with PCOS, or severe menstrual cycle irregularities or severe menorrhagia, you can dose the progesterone orally for 3 weeks on and 1 week off, and that seems to help those folks with more severe estrogen dominance a little bit more than the 2 weeks on approach. I usually get progesterone levels around day 19 to 21 when I'm assessing a woman's level. Normal is somewhere between 2 and 30 nanograms per ml. You could do salivary testing also as a baseline. There's some interesting functional labs out there that do 28-day saliva tests. And you could do a 28-day saliva test if you're really trying to catch when the peak production of progesterone is. But generally, if a woman is symptomatic, we do just a blood test and we go ahead and prescribe oral progesterone. In postmenopause, the dosing is pretty similar. We usually start somewhere between 100 and 200 milligrams. That is dosed every day in that case. You can use a compound pharmacy to make micronized progesterone. I typically do that as a troche, which is a lozenge. A troche version of progesterone, you can put as much as 200 milligrams in a troche. So if the woman is on 100 milligrams, they can break the troches in half and save money that way. Otherwise, you can use commercial products, which are bioidentical. The one that comes to mind is Prometrium. Prometrium, you're kind of stuck with a fixed dose. That comes in 1 and 200 milligram strength. But if a woman wants to use her insurance, that's a good option. And this is continued cycling. I wrote a note here. Some prescribers like to create off days. There's no real literature on creating off days, so our preference and how I was trained is just to, in postmenopause, give progesterone every night. Let me go to the next slide here. For lab work and monitoring, I tend not to chase numbers, but progesterone should be somewhere between 2 and 20 on follow-up, depending on your lab's reference range. I tend to use Quest or LabCorp. If you're using progesterone at night, which is typical, AM draws are the best to try to catch the levels. If it's been more than 24 hours since their last dose, you're probably going to see a lower level than you would expect. Serum testing is great for oral progesterone. We get a nice predictable rise, and I'm a big fan of serum testing in this case. If you're using topical testosterone, you could use saliva testing, but even in the case of topicals, you could also use serum. I don't do a lot of topical progesterone, and mainly that's because oral progesterone has so many extra beneficial effects in terms of being a natural anxiolytic. It's more predictable, and there can be issues topically with different women and their ability to absorb things, plus different bases that might be used by compounding pharmacies. So my tendency is always to use oral progesterone for those reasons. Plus, oral progesterone goes through the liver through hepatic metabolism. In this case, the liver metabolism is a very good thing, and it turns progesterone into 5-allopregnenolone. This is a kind of Valium-like hormone that is a direct GABA agonist in the brain and helps much more with sleep issues. Many women, especially if having PMS or postmenopausal, suffer from insomnia. And topical progesterone does not help as much as oral for treating for the GABA effect, which you get with oral. Here's some studies on progesterone. So these are studies on real progesterone if you dig in the literature. Progesterone helps with coronary artery spasm. It helps kind of thin the blood. You can read some of the studies here. There's primate studies where they showed that hydroxyprogesterone acetate, so synthetic progestin, increased vasospasm, whereas real progesterone did not. Here's some more studies here. Progesterone decreases the risk of breast cancer. Synthetic progestins increase breast cancer risk. That's well documented in the Women's Health Initiative study, people taking Premarin alone versus Premarin and hydroxyprogesterone acetate. There was a huge difference in the risk of cancer. Real progesterone decreases breast cancer risk. I talked about that earlier. Women who produce more natural progesterone have less breast cancer later in life. And here's some more statistics on that. Pregnancy, progesterone, and progestins in relation to breast cancer risk. You can read that article there. There's a prospective study with over 1,000 women treated for fertility, and they showed that the women producing the lowest amount of progesterone actually had 5 times increased the risk. So again, thinking about breast cancer risk reduction, you can actually start thinking now about hormones. Hormone therapy is a way to decrease a woman's risk of breast cancer. And that is not a super new idea, but it's an exciting idea, especially if you know a woman is estrogen dominant, if she has a family history of breast cancer, if you know that she's underproducing progesterone and you catch her in your office at age 30, then you have an opportunity to balance her estrogen-progesterone ratios and possibly decrease this 5.4 times associated risk you're seeing in the slide there. Here's another study showing bioidentical progestin decreased breast cell proliferation by 66%. So this is another reason to use progesterone for breast health. And typically, if a woman had a hysterectomy, they're just offering her, Vivel patches, estradiol patches afterwards. But it's not only the uterus that needs progesterone. Many other tissues benefit progesterone. We talked about the breast here. I talked about the brain earlier, cardiovascular system. So many, many reasons to give hysterectomized patients progesterone, though the OBGYN community is maybe not aware of some of these studies and protective effect of bioidentical progesterone. There's lots of studies on progesterone and neuroprotection. Some people are thinking about using this in traumatic brain injury, but progesterone stimulates the release of dopamine and growth hormone releasing hormone from the hypothalamus. It also modulates oxytocin from the hypothalamus, which you can see there. It potentiates GABA, which we talked about earlier. So lots of benefits to the brain using progesterone. So the next sort of arm of classic bioidentical hormone replacement is the use of estriol and estradiol. Estrogen does many, many things for men and women. For women, it increases their good cholesterol, decreases LDL and triglycerides, obviously helps with their bone density, increases serotonin, so it's a natural antidepressant. It also increases blood flow into the brain. So one of the reasons why women have a complaint of brain fog at menopause is because when estrogen declines, their ability to circulate blood to the brain is somewhat compromised. Helps maintain memory. There's lots of studies on Alzheimer's disease and estrogen. Maintains skin collagen. We commonly compound forms of estriol for sort of anti-aging facial aesthetics because it improves the ability of the cells of the skin to not only be elastic but to retain fluid. Improves sleep, works as an antioxidant, reduces cataracts, many, many, many things. Estrogen deficiency, of course, is associated with many symptoms clinically, which would be hot flashes, osteopenia, osteoporosis, night sweats, fatigue, vaginal dryness, or dryness of any skin tissue, dry eyes as well. Fine lines above the lip, I would add to that. Dry, flat, coarse hair, poor memory, foggy thinking, low energy, decreased mood, and you can read the rest there. Many women who are low in estrogen, when they come into my office, we hear things like, I feel like my body is divorcing itself from me. That's kind of a common way it's stated. Memory problems, just not feeling right, feeling emotionally imbalanced, crying easily. Those could all be signs that your patient is low in estradiol. Estriol is often used in combination with estradiol in bioidentical hormone replacement. There are studies even in Japan using estriol alone as a treatment for menopausal symptoms, and it does work to increase bone density, help with vaginal dryness and hot flashes. But estriol also has potent anti-cancer effects. You can see that it binds preferentially to the beta receptor in the breast, and overexpression of the alpha receptor is associated with increased risk of breast cancer. When you use estriol along with progesterone, you're really doing two things to limit the potential proliferative effect of estradiol on estradiol receptors in the breast. Women with low estriol are associated with increased breast cancer, according to some studies. So if you bring that back, again, that's a hormone produced more by younger women. So by the time menopause hits, the level of estriol produced is not as much as it used to be, and women are making more estradiol and estrone. Here's another study showing that E3, which is estriol, inactivates the cancer gene. So we're big fans of estriol, and typically estriol and estradiol are split 50-50 in some of our preparations, which I'll talk about in a little bit. There are many ways to do estrogen replacement therapies. There are commercial products, there are compounded products. These can be delivered topically, vaginally, or in pellets. We do all of the above at this clinic, and I can speak to that if anybody has questions about pellets later. Oral estradiol is not a great thing, so that's why I put this slide in here. Oral estradiol, lots of women come in on troches of estradiol or oral estradiol capsules, which are available commercially. Here's why you don't want to use oral estradiol. It can increase a woman's blood pressure, increase triglycerides. Through hepatic metabolism, which in this case is a bad thing, you can get more conversion to estrone, which is associated with cancer in some studies. It can increase gallstones, which you don't want to do in this age population. Increase in liver enzymes, SHBG, which we see a lot on women with taking oral estradiol. Serotonin metabolism can be affected, and you can read the rest here. Lots of people ask me if bioidentical hormones cause clots, and I had a conversation with an MD the other day, and she was, convinced that this was the case. But if you look at the literature, you'll find study after study showing that topical hormones do not increase the risk of thromboembolism, period, and it's pretty much the end of the story because no study to date has shown that bioidentical hormones transdermally do that. And you can read, I have all the references in the slide set, and I'd be happy to share those with anybody later who wants these. Many, many studies on this topic. So why are we doing this? What are the benefits of estrogen? Well, again, if you catch this early in a woman who is, just hitting menopause, potentially you can prevent bone loss or further bone loss. Estradiol is a natural antidepressant, so that's a good thing. Estradiol improves insulin sensitivity, so this is relevant for a lot of our patients with blood sugar abnormalities. Obviously, this reduces hot flashes and vaginal dryness. E2, which is estradiol, also lowers C-reactive protein. So potentially you're getting improvement in cardiovascular risk factors as well. You can even reverse some atherosclerosis. Women who are started early with estradiol probably have less risk of heart disease and Alzheimer's disease as well, according to the literature. So here's some kind of clinical pearls. If you're using estradiol in a menopausal patient, you know, my typical approach is to split the E3 and the E2 50-50. Other people do 80-20 combinations. This can be formulated, as I mentioned earlier, topical or vaginal creams. I have a preference for vaginal creams because many of these women also have atrophic vaginitis, you know, vaginal dryness, and you have kind of an opportunity to ameliorate that as well as get very good systemic absorption. How the vaginal creams are prescribed is they're concentrated into a 1 cc syringe, and the women use 1/10 of a cc daily vaginally. Half of the amount gets applied between the outer and inner labia, and the other half gets applied intravaginally. And if they apply it in that way, they get very, very good absorption and a good local effect. Topical creams can be used. There are some dose ideas there that you can see. Topical creams are pretty good. You get a pretty predictable rise that way as well. But some women don't absorb as well, like in the forearm, for example. And for that reason and many others, I'm just a bigger fan of the vaginal route if a woman tolerates it well. Here's some examples of how to prescribe this on the bottom. If you were to prescribe Biased as an 80-20 formulation, you would write Biased 80-20 5 milligrams. The pharmacist would know that that's 4 milligrams of estriol E3 and 1 milligram of estradiol per ml or per gram. That's the same thing. An example of a 50-50 preparation, you could write that as Biased 50-50, 2 milligrams per ml. The pharmacist would know that's 1 milligram of E3 and 1 milligram of E2. I tend to remove the Biased nomenclature because it creates confusion. So in my prescriptions, I just write, you know, E3, 3 milligrams, E2, 3 milligrams per ml, SIG is 0.1 cc's PV Monday through Friday, and I'll talk about that in a second. Here's my slide, describing the advantages of vaginal administration. You get a local and a systemic effect. If you concentrate it, it's really cheap. I mean, these pharmacies usually charge per the cc. So if you get 10 doses in 1 cc, potentially this is, $5, $10 a month for a vaginal estradiol, and we usually mix that with testosterone, which I'll talk about in a little bit. Vaginal dosing, here's an example, 0.1 milligrams of estradiol up to 0.5 milligrams. I've settled on a dose of 0.3 for most women. That seems to work very well. So I use 0.3 per 0.1, which is 3 milligrams of E3, 3 milligrams of E2 per cc. So 0.1 cc is 0.3 milligrams of E3 and E2. And there's the application instructions on the bottom of the slide. On follow-up testing, if you're trying to alleviate symptoms like hot flashes and vaginal dryness, the magic number seems to be 30. I've noticed better results when we get women in the 30 to 100 picogram range in follow-up testing. So if you're using serum testing, again, you're going to see a nice predictable rise in serum using vaginal administration. I usually get the levels checked somewhere between 2 and 12 hours after administration. If you wait too much longer than that, you might not see that predictable rise you're looking for. I look at estrone too on follow-up testing, so I'm usually looking at estradiol and estrone. I like that to be less than 100. If it's not, there are some supplements that could be used, which I'll speak to later. One thing you can offer women who have histories of breast cancer, are worried about breast cancer risk, or you're perhaps worried about the risk of breast cancer based on various factors, is 2,4,16-hydroxyestrone testing. You can do this through various functional labs. If those ratios are not in alignment, if this estradiol is not going through the liver in the most beneficial way due to genetic mutations or poor diet or otherwise, you can catch this on a 24-hour urine test. 2,4 and 16-hydroxy, the best mnemonic for thinking about this is the good, the bad, the ugly. If they have a bad, a lot of 4-hydroxy or 16-hydroxy, you can use supplements or brassicasea vegetables to modulate that. Here's a note about HRT bases. This adds further confusion to trying to prescribe compounded creams, but essentially compounded HRT creams come in a variety of bases. Versa base is best for vaginal application, and Lipoderm probably has some of the best data on it for topical. The PCCA folks have vetted this out pretty well, and they've discovered you can combine 4 different drugs in Lipoderm, and they all seem to get absorbed due to some of the research. Carbamor gel, I don't use a lot of. I use that sometimes for men with testosterone. It's kind of an alcohol base, and you might get better absorption with that, sometimes over Lipoderm if you're using topical. Some customers like organic bases. There's a few of those out there. You can talk to your pharmacist. They sometimes use jojoba oil. Well, let's talk about testosterone. There's a lot of exciting things about testosterone in women, lots of great new studies. There's a wonderful study I'll highlight in a minute by Rebecca Glazer showing decreased risk of cancer in women using transdermal testosterone, which we're all really excited about. What does testosterone do for women? Well, it does a lot of the same things for men. You know, obviously it helps with muscle mass, body composition, ability to burn fat, sex drive, memory. Women who are low in testosterone also have more depression and lack self-confidence, so that's something that can be restored with testosterone replacement along with libido. Women on testosterone also notice an enhanced sense of well-being, and testosterone levels decline around the same time as progesterone. In the 40s, usually women get a slow and steady decline in testosterone. If they're adrenally fatigued or have any adrenal axis issue, obviously 25% of their testosterone is made in the adrenal gland. So if that's an issue, you're going to see lower testosterone levels in those folks. And if they're a 20-something-year-old and they have low testosterone, that could be a potential cause. And we do replace testosterone in younger women if they're symptomatic and we're unable to restore it by optimizing adrenal function. Testosterone deficiency in women is associated with some of the things I mentioned earlier. Terry Hertog likes to talk about thinning of the lips, thin upper lip can be associated. Anxiety, sagging cheeks, droopy eyelids, muscle weakness, osteoporosis, low libido, fatigue. I would say issues with self-confidence. I've had a few patients who are CEOs, and in perimenopause, we caught them in perimenopause, and they weren't as excited about going on job interviews. They seemed to lack the self-confidence and sort of type A personality that got them into their high-profile positions. And when we restored their testosterone, they were kind of back to their, vigor in that sense. Serum testosterone is pretty straightforward. The reference range, somewhere between 10 and 80 nanograms, depending on the lab you use. Free testosterone levels for women are somewhere in that range, 0.2 to 3-ish. I recommend treatment if they're, low or low normal and symptomatic as part of a general HRT protocol. Target range for total testosterone, I like to see it somewhere between 50 and 150. Once you get over 200 in a woman, they usually start to become more symptomatic. They can have excess facial hair growth or acne. And free testosterone between 2 and 10 seems to be pretty good. Topical dosing, there's some dose ideas for you, a quarter of a milligram up to a couple milligrams if you're using a topical Lipoderm base. Vaginal dosing, you don't need quite as much. I've settled on about half a milligram vaginally. That seems to work very well for my female patients. So again, half a milligram per 0.1 ml is 5 milligrams per ml, so you could write it that way. And the SIG would be 0.1 mLs PV Q day. And that will deliver half a milligram vaginally daily. You can also do this via a sublingual lozenge known as a troche, and there's a dose range for you, quarter milligram up to 2 milligrams. Just a note on troches, they have a shorter half-life, so the troche will probably be out of their system a lot faster than a pellet or a transdermal application. And I like to monitor all these things if done topically in this kind of 2 to 12 hour after administration range. Some of the literature here, here's a study, again in Maturitas. The predominant data shows that low-dose testosterone use is safe in regards to the breast and endometrium, with experimental data suggesting a decrease in estrogen-induced breast epithelial proliferation and no adverse cardiovascular events. So these are studies to be aware of. Testosterone seems safe, number one. Two, again, not associated with the side effects that we're seeing in the Women's Health Initiative study looking at synthetic hormones. Here's a great study, again, by Rebecca Glazer, I mentioned earlier. She had a cohort of over 1,000 women. She uses a lot of pellets in her practice, and she found that women getting pellets of testosterone had a decreased risk of breast cancer. And that's a good power, behind that study, over 1,000 patients. And she matched them to, age-appropriate match them. Here's another study, breast cancer incidence in postmenopausal women using testosterone in addition to usual hormone therapy. So you can read about some reviews on that. There was a double-blind trial in CHF and testosterone therapy that's kind of interesting. Of course, testosterone, because it helps with muscle, may be beneficial in the context of CHF. And obviously, this helps normalize sexual desire, dysfunction, orgasm frequency, other issues like vaginal dryness and hot flashes. Testosterone by itself can normalize. Some women with breast cancer histories, we use testosterone or testosterone with estriol vaginally, and they do very well, and we have a hormone replacement protocol that involves no estradiol if they had a history of breast cancer due to estradiol receptor positive. DHEA, a little bit about DHEA here. A lot of clinicians use DHEA. There's a lot of good data on DHEA in terms of bone density in women. We usually dose this, I usually dose at 5 or 10 milligrams. If you get much higher than that, you can have a lot of conversion to other hormones. Sometimes that can convert to estrogen, which sometimes you don't want. And higher doses, of course, can convert to testosterone. And if they're already on testosterone or they don't need testosterone, and you're using a higher dose of DHEA, you can get unwanted testosterone conversion. So a typical dose, in my practice is 5 to 10 milligrams orally. You can also do this transdermally or vaginally, but again, oral dose of DHEA gives a very nice predictable rise in serum DHEA sulfate. So what we typically test for baseline is DHEA sulfate. The reference range on DHEA, is somewhere between 20 and 200. Optimal range, we think, in sort of the anti-aging movement is probably somewhere between 1 and 200 in a female patient. DHEA decline begins, starting around age 30. It's associated directly with aging, and for all intents and purposes, this is an anti-aging hormone. This is a hormone produced by the adrenals. It's an anti-stress hormone, and it's an anabolic hormone. So this is going to help with growth and repair of tissue in regards to muscle mass and bone density. I've had patients in the past who, don't need any other hormone, but they're low in DHEA. We give them DHEA, maybe they're pre or perimenopausal, and all of a sudden their workouts are better, they're burning fat better, and their energy, endurance, or stamina is increased. You can do this as a trophy as well, so I wrote down a dose idea for you there if you like that approach. And we usually check blood levels. Of course, you can check DHEA and saliva as part of a adrenal function test. And if you see it's low there, you could supplement with oral and then kind of track it, getting serum DHEA testing and shooting for that target of 1 to 200. DHEA studies, I have a few here. Randomized trial of oral DHEA and sexual function well-being and menopausal symptoms. You can read that, improvements in arousal, lubrication, and sensation of orgasm with vaginal DHEA administration. So that's an interesting study there. And it was noted that there was no negative effect on lipid profile or insulin glucose homeostasis or the endometrial lining with 50 milligrams of oral DHEA. And I would add that there's studies done in lupus where they've used doses 200, 300, 400 milligrams of DHEA, and they did not notice any side effect with higher doses on that. Putting it all together, so we talked a lot about different dosages and compounded forms of these hormones, and I kind of put this slide together to make your life easier, but this is how I typically prescribe hormones in my practice. If it's new onset, we got a woman who is menopausal, she's having symptoms. Again, my go-to is either going to be pellets or creams. If we're doing creams, I would write it like this, E3, E2T, 335 milligrams per ml. So you're getting 3 milligrams, 3 milligrams, 5 milligrams per ml or per gram. It's the same thing. and the sig here is 0.1 PV Monday through Friday. You could do this daily. I do this Monday through Friday. I have women take the weekend off just to make maybe compliance a little bit better, and it seems to work very, very well. Alternatively, if you're using combinations of testosterone and estriol and estradiol topically, you could write it like this, 112 per ml, and a woman could use half an ml topically daily. If they're doing this topically, you want to use an area where there's good absorption. The wrist is good, forearms are good, elbow crease is good, the neck is good. Terry Hertog really likes that idea as well. That's the area between your clavicle and your jawline. There's good absorption. You could use the inner thighs or behind the knees. Avoid using the same area over and over again, especially if it has testosterone in it. That could cause unwanted hair growth, and avoid areas where there's lots of hair. Hair follicles have other enzymes in them which could affect conversion. If we're using troche, there's some dose ideas for you there. Progesterone capsules, typically I start with 100 milligrams. It can be sustained release or not. It's kind of a fine-tuning point, but this is oral micronized progesterone, QHS. I usually write this as a troche, so that's why I wrote that underneath. Example, 200 milligram troche, half a troche QHS. Then if the woman needs a little more, if they're still having anxiety, if they have any breast tenderness, if they're feeling fluid retentive or having bloating, and you want to increase the progesterone as a way to further balance estradiol or just help with the things progesterone helps with, you could go to 150 very easily then by telling the patients, take 3/4 of a troche, and then you could titrate up very easily to a whole troche. So troches give you the advantage of self-adjustment, which creams do as well. And then DHEA would be 5 milligrams usually to start, and then see kind of where the blood levels look afterwards. If we're using pellets, generally this is estradiol mixed with testosterone. There's a couple schools of thought here. The school I subscribe to is a little more testosterone, a little less estradiol. So typically we start women with somewhere between 100 and 200 milligrams on the testosterone, and they get usually about 12.5 to 15, not 50 milligrams of estradiol. Those are usually 3 separate pellets in that case. They get implanted through the subcutaneous fat tissue of the buttock, and they deliver hormones over a 4 to 6 month period. To that protocol, you would still add the oral progesterone at night, and some women do absolutely fantastic on this. If a woman has very, very low libido, this seems to work better than anything else. If a woman had a hysterectomy, this seems to get her restored and back to how she was prior to the hysterectomy much faster. And for some women, they just always feel better on a pellet, so they just continue doing that. So I've been doing pellets for about 1.5 years, and I was trained in Las Vegas, and I can tell anybody who's interested where I got training for that. It's a good therapy. It's not that much more expensive than doing a bunch of different topical compounded versions of similar things, and some women definitely prefer it, so that's something to consider. Common HRT issues that I've come across in my practice. Some women occasionally will get a UTI or yeast infection. Possibly we're changing the pH by introducing a vaginal cream. If that happens, I would, usually tell them to just try to stay the course. If it's happening routinely, possibly change the base or switch to a topical route or some other route of administration. If they're having a complaint of fatigue, especially in the morning, if they say things like, I feel like I'm walking through sand, the dose of progesterone could be too high. That's pretty uncommon. I don't see that very often. Symptoms of too much testosterone are there. We do see these occasionally. Extra facial hair growth or acne. You can lower their dose, or you can add saw-palmetto, spironolactone, or even drugs like metformin if you're temporarily trying to block testosterone. Or you can lower their dose, which is the most simple way to take care of that. If it's a pellet, you can't really lower the dose, so you're kind of more relegated to some of these ideas in the slide there. Breast tenderness usually means there's too much estrogen in their dose, or they're just absorbing it too well. If that's the case, we usually decrease the dose of the estradiol or increase the progesterone. So that's usually what I do. Hot flashes, likely there's not enough estradiol. There's also some new studies pointing to just using progesterone for hot flashes. So if they have hot flashes, be thinking estradiol, but possibly also they're underdosed in progesterone. That could be possible. persistent vaginal dryness, even though you're using a vaginal cream or even though you've got a pellet or topical cream and you're getting good systemic absorption, you could prescribe an E3 vaginal cream by itself, or of course you could prescribe commercial products like Estrace or Vagifem. Those things are pretty expensive though, and compounded E3 cream is very cheap. The dose for that is usually, 1 to 5 milligrams per ml. Apply an ml every day for a couple weeks, and then as needed for vaginal dryness after that.
And see my screen. Jeff, thank you so much. You covered so much information. I was scrambling here taking notes, and we have quite a few questions. So I don't know what your time frame is. Do you have time, like maybe 5-10 minutes to go over some?
We're good.
Okay.
We're good. And just to speak to that, it is a huge topic, guys. I appreciate everyone for sticking through. I tried to cover a lot of ground, and as a consequence, was probably talking very, very fast. This type of thing requires a lot of study, and there's some great organizations I can talk about that do lots of training in all the different areas that I touched on. But thanks for bearing with me as I tried to kind of blast through a lot of information.
No, it was fantastic. We're going to make this available for everyone for a recording. So if people do, need to go back and listen to, which I think many people will, they'll have that option. And then just want to make sure that you guys are all aware these webinars are sponsored by Zymogen. Many of the products that Jeff mentioned here are at a significant discount for 72 hours. So you have till Monday to get that going. And then there's one that we didn't really have a slide for, but I did want to pick Jeff's brain on because myo-inositol and taurine, theanine, GABA, all these different things are something that you found clinically to be effective. Any highlights or stories that you can share with us, Jeff, about your use of RelaxMax in your practice?
Yeah, so RelaxMax is a great Zymogen product. It combines everything Mike just mentioned, the myo-inositol and theanine and GABA, and there's one more thing in there, Mike, I'm missing. What's
taurine.
Taurine, yeah. And so clinically, RelaxMax, 1 scoop twice a day for patients who are anxious is wonderful. We have patients even who meet criteria for more moderate to severe anxiety, and I've used RelaxMax successfully. We do a lot of IV therapy in my practice as well. So RelaxMax is something we give patients before blood sticks or IVs in patients who are anxious, even before procedures. I didn't talk about this much, but our clinic kind of bridges regenerative orthopedics like stem cell therapy and PRP with what I do in functional and anti-aging medicine. So a lot of patients come in with basically the need for interventional injections, many of whom are anxious. So we just kind of have this out at the MA station, and we give this to patients, and 10, 20 minutes later they can get their injection without feeling as anxious. To speak to some of the other ingredients in there, I mean, you could talk for 5 hours just on those 4 things. Yeah. But myo-inositol has been beneficial for things like PCOS. There's a lot of great literature on insulin sensitivity in that, so it's another reason to use it. Plus, it activates GABA receptors in the brain. That's why it's in that formula. Taurine is a kind of a mild GABA agonist, which is a great way to relax, as well as there's a lot of data on taurine and liver health and cardiovascular function. And theanine, as you probably all know, is probably one of the best studied things lately for anxiety. The studies are good, and good. There's no side effects really at any dose that I've seen. And 1 to 200 milligrams of L-theanine up to 3 times a day, if nothing else, is wonderful, but in tandem with some of these other things is great. So if you have patients who are menopausal or perimenopausal, they're typically going through a lot of symptoms of anxiety, insomnia. So you can also use this for your insomnia patients who are not responding to a single agent. You can combine this with the progesterone and the melatonin that I talked about earlier.
Yeah, fantastic, Jeff. And I just want to highlight, you touch on the myo-inositol and all the PCOS and metabolic properties. I think it's kind of like the estrogen, bioidentical estrogen research and progesterone research that you mentioned. It gets hidden, and a lot of practitioners don't know about it. And there's so much data on ovulatory function, even insulin sensitization in men. There was one study that looked at LDL particle size, looked at C-reactive protein. So there's many metabolic effects. So this is really, covering multiple bases. You mentioned all the, anxiety and maybe mood disorders and so forth, but there's also all the metabolic things, which, as many of you know, are linked with mood disorders. So great product, great price point on that. And then wanted to run through some questions here and make sure you guys saw that this was available. So we talked about, this is a chart that's made by one of Zymogen's board of advisor members, but I'm going to zoom in here and show you the 4-hydroxy metabolite that sulforaphane works on. So that was if you remember, the Hormone Protect, where it has the diindolylmethane that works, kind of up here and reducing the 16 alpha and increasing the 2. but also reducing the 4-hydroxy. So great resource. We'll email this out with the video to everyone tomorrow. And we'll dive into some questions here real quick. Where are these guys? Okay, so I don't know if you can see this, Jeff, or not, but is there a U-shaped curve? I mean, some women that are elderly, is there any point at which these hormone balancing therapies that you mentioned would not be beneficial?
Here's what I would say. If they're symptomatic, I would use hormones, and I would try to get them into the types of ranges that I mentioned before. Where you're not going to see benefit in elderly patients is probably Alzheimer's risk reduction and cardiovascular disease risk reduction. If you wait till 10 years post-menopause, those benefits are probably not going to be there according to the literature. So basically, you would be trying to use them for some of the other things the hormones can help with. If they're sexually active, have vaginal dryness, if they're having hot flashes, sleep disorders, there could be some indication to use them. And again, we don't have data showing that that's a bad idea or that it's going to increase the risk of any type of pathology. Plus, many older people have issues with muscle mass and bone density. So you may get some benefit at least with sarcopenia using testosterone, for example.
Perfect. Now, along the lines of testosterone, have you ever found any increases with just using DHEA to increase serum testosterone to a point where people actually notice something physiologically?
Yes. Yeah, we have. And sometimes it takes 25 milligrams to do that.
Some people are asking for your slides. What do you think on that?
We'll talk. I'll talk about that with Mike later.
Yeah. I think just what I would say is we'll make the video available, but this is, you do speaking for other organizations and so forth. So I think we should not give away the slides. But we have the video available, and if you take good notes, all the references, it's highly referenced, so you can put them together. But this is something Jeff spent a lot of time putting together. So you have the video and the audio. Do you have a time frame or age where you would not consider BHRT? Maybe too young, and we already covered too old.
Too old we covered. Too young is not something I've thought about a lot. I'm an adult nurse practitioner, so I start seeing patients at age 18. Probably my youngest patient on testosterone topically is like 25. I would certainly consider progesterone in any age. I've treated people age 18 and older with progesterone. I'll give you one clinical case study here. I had a patient coming to me with severe menorrhagia to the point where she was prescribed 2 birth control pills a day, so she was doubled up on her birth control, and she was having side effects due to birth control, plus I wasn't super excited to have her take so much synthetic hormones, which you can see why after listening to this slide set today. So anyway, long story short, we put her on 300 milligrams of oral progesterone. She got off the oral contraceptive pill, and she did much, much better, and now she's actually on 200 milligrams, and she has no menorrhagia anymore at all. So interesting fact there, the bioidentical progesterone is actually working better than a double dose of synthetic oral contraception.
Wow. It's pretty amazing.
I would not use that. To speak to estrogen, though, we rarely use estrogen before perimenopause. Once in a while, so unless there's a surgical hysterectomy or surgical menopause, or menopause that was created for some other reason at a young age, then you would use estriol, or estradiol, estriol combos. But if somebody is menstruating regularly, I may have only had one case where we used a little bit, and it could have been for vaginal dryness. I can't remember.
I just thought of something as you were speaking about that last patient. Is progestin and progesterone, are they the exact same biochemical?
No.
Okay, so it just highlights the whole structure function thing when it comes to strain-based probiotics, when it comes to folic acid versus 5-MTHF, is if you have a molecule that kind of looks like another molecule and can be patented and all that, it's not the same molecule. So why would we think that the benefits would be the same?
These are wildly different molecules. My favorite speaker on this topic is Dr. Eldridge Taylor. He's in Atlanta, but he just throws up a slide on this is really funny, guys, so just listen to this. He slows, at the beginning of his presentation, he throws a slide up on the screen, and he says, one is progestin and one is progesterone, and they're the molecular structure. And he's like, who in the audience, can tell me that those molecules look the same? And of course, no one raises their hand because they look different. And he says, okay, you're all honorary gynecologists.
Nice. Wow,
because it's that simple. Bioidentical hormone is that simple. We're using what's created by the body naturally. We're trying to recreate a balance that the body is used to. and we're using substances that get delivered in the appropriate way, and we're following our patients appropriately.
Mm-hmm. Yep. Gosh, makes a lot of sense. So we have a couple more here I want to dive into. So for a woman that's nursing, what do you think about HRT?
Yeah, HRT is fine in that context. So if she's nursing and needs progesterone, for example, if she has postpartum depression or menorrhagia or any of those types of things, you could very, very safely use progesterone. Testosterone, I would probably not use if somebody is breastfeeding. Progesterone is very, very safe. They produce it anyway. And again, if you just get their levels into a physiologic range, it's nothing that the infant wouldn't have encountered if they were producing more progesterone, normally. But I would reserve DHEA and testosterone in that scenario.
Mm-hmm. A couple questions on testosterone since we're on that topic. What about oral compounded testosterone, the troches and things? What do you think there? And then there's a second part to that. What's the average dose?
Oh, for a troche?
Mm-hmm.
A troche, you're probably looking at 0.5 milligram up to 2 milligrams as a sublingual lozenge. So you could dose it, 2 milligrams per troche, and you could start them at a quarter or half a troche sublingually once a day. Some people do it twice a day, but there's issues with compliance around that. So I would typically just do that once daily. I prescribe a little bit of troche, but not a lot. And the reason is because I end up just combining it with the estriol and estradiol in the vaginal creams or with a pellet. But some women come to me on troches and they're doing great, so we keep it going. And that's a typical dose for that. And you could follow those levels in serum, again, 2 to 12 hours later after they put the lozenge under their tongue. And I have no real issue with that. These are pretty low doses of testosterone. Some people are worried about hepatic metabolism when it comes to bioidentical testosterone. And I'm still kind of looking for research on that. I haven't seen any liver enzyme elevation or anything like that with troches in women.
Yeah, 2 milligrams, pretty insignificant.
Yeah, I'm not worried about testosterone troches in women. Where I do have a slight concern is in the estrogen component of that. We definitely see elevated SHBG, more estrone. You'll typically see estrone between 1 and 200 if a woman is using oral estradiol.
So more aromatization
Not always,
then?
but we see it a lot.
Yeah.
Yeah, they're converting it through hepatic metabolism from estradiol to estrone. And that's probably not something we want to do. We want to keep estrone levels under 100 if we can. And if we can't, speaking earlier to some of the Zymogen products, we've seen some of those things lower estrone as well.
You kind of touched on it, but let's just solidify this. So if someone does need, via lab work or symptoms, it's testosterone primarily seems to be the indication. The question was, when do you know when to add in E1 or E2? I guess this just comes back to we need to look at comprehensive laboratory panels.
Yeah, that's exactly right. So again, if the patient is perimenopausal and they're not yet low in, this is a very classic scenario. The woman is perimenopausal, maybe they're having some symptoms of low progesterone, but also testosterone is low. You can add testosterone in, and as soon as you start seeing clinical symptoms of low estrogen, or the lab work reflects that, usually it's a combination of the two. They start having night sweats, hot flashes, vaginal dryness, mood alterations, brain fog, dry skin, etc. Then you throw that in when it makes clinical sense. And so we have a lot of women, they start in perimenopause. We start just with testosterone. I've done just testosterone pellets by themselves in perimenopausal women. They do great. And then at that certain point, you start to see those other symptoms. And estradiol is a funny thing, it drops off kind of right at menopause. And in perimenopause, it's usually, you'll see serum levels between 30 and even 250 sometimes.
Wow. Interesting. So we did have one live question. Audrey, you're live. Audrey Vaughn, did you still have a question? Hello? Guess not.
Okay.
All right, Jeff. Well, thank you so much. This was excellent. Again, I really appreciate all the work and time. I mean, that presentation, I don't know, you probably have 100 references there. So congratulations to you on that. Well delivered. We'll make sure we get the archive out to everyone. Again, you do have this special. The code is SPWeb81314, the date today, on these amazing products that will be available for 72 hours. And Jeff, thanks so much, and hope you have a wonderful evening.
Thank you. Thanks, Mike, and thanks, everybody, for listening.